entity, one that you think about a lot but rarely see. It's called cerebral vasculitis. These are my disclosures. The main ones are in yellow that have served as a medical expert witness in a few cases of RCVS or vasculitis. And I've written chapters for Up to Date and for MedLink. Today, I hope to illustrate the key clinical and imaging features to help you accurately diagnose the two conditions and distinguish them from other cerebral arteriopathies, and also show you how it's best to manage patients with these conditions and, most importantly, avoid common pitfalls that can lead you down the garden path or really result in poorer outcomes of patients if not managed properly. So in general, arteriopathies, I think, are one of the most, probably the most common causes of stroke, even more common than cardiac causes if you account for things like atherosclerosis of the carotid or intracranial arteries, small vessel diseases such as lipohyalinosis, and all the other arteriopathies. If you pull them in, and if you go to the younger populations, arteriopathies predominate as the cause of stroke. You can classify them in various ways by the mechanism, whether genetic or not, and so on. But I think, practically speaking, when you first see a patient, the question is the angiogram normal or abnormal? If the angiogram is abnormal, you think of large or medium-sized arteriopathies, and the most common ones are listed here. Dissection, of course, mainly in the neck, but it can be intracranial. Intracranial premature atherosclerosis in the young is very common now. RCVS, in my personal experience, is the third most prevalent. And then you get into rarer arteriopathies such as moyamoya, sickle cell, Fabry's, fibrobuscular dysplasia, Takayasu, and then rarely, I think, antiphospholipid antibody-mediated MCA stenosis. And then the infections, which I think worldwide infection is probably the most common cause of cerebral arteriopathy. When the angiogram is normal, we think of small vessel diseases, and this is where primary angiitis of the CNS comes in. Sometimes it can also cause medium vessel arteriopathy. That's primary angiitis. And then all the rest are written here. As I said, RCVS in my experience is pretty common, and I've been seeing by the clock one patient every 3 weeks admitted to Mass General and in the outpatient clinic as well. But that could be a referral bias to me. And I've accumulated more than 300 patients personally in my career, so it's not uncommon. Another way to think about arteriopathies is whether they're going to keep progressing and cause more harm, or are they benign and reversible? So RCVS belongs to the former, and vasculitis belongs to the inflammatory progressive arteriopathy. Many of the other arteriopathies on this slide are also progressive in the absence of treatment, for example. Okay. So what is RCVS? RCVS is, I'll start with the prototype case. This is somebody I had seen during my residency, a 46-year-old man with an acute 10 by 10 postcoital headache. It was a rather dramatic presentation. Working in the ED, we thought it was a brain aneurysmal hemorrhage. However, the CT scan didn't show any blood, and the CSF examination ruled out xanthochromia. Nevertheless, a CT angiography study showed widespread multifocal, as you can see with the red arrows, narrowing and then dilatation, narrowing, dilatation, narrowing. So kind of a sausage on a string appearance of the intracranial circle of Willis arteries and their branches. This is the prototype presentation of RCVS. Worst ever headache. They come in, they're very sick looking at the beginning, and there's intracranial arterial narrowing, either on the first CTA or over the next 3 to 5 days it develops. Most patients have this recurrent 10 by 10 thunderclap headache. Thunderclap as in 0 pain to 10 by 10 pain within 60 seconds. Recurrent headaches are the norm, and this patient went on to say he's had blurred vision, And when I examined him, he had elements of the Berlin syndrome, which is one of the cortical blindness syndromes. And sure enough, the initial MRI had normal, but the follow-up MRI, when he became symptomatic, did show these bilateral occipital pole infarcts, which are in the watershed between the middle and the posterior cerebral arteries. You can imagine how if both the arteries are narrow, this is kind of the watershed. So we think of them as watershed infarctions. However, over the course of the next 3 weeks, without any specific treatment, this patient's vision improved. The arteriopathy resolved as shown over here. Now, at that time, it was a learning curve for me because I consulted several different faculty. And as a resident, I got several different answers. So I remember this quote from Buddha, which said, "Believe nothing, no matter where you read it or who said it, until it agrees with your own reason and your own common sense." So for this patient whose images I showed you, one faculty said, "Oh, this is cocaine exposure." The second said, "This is premature athero." The third said, "This is a small aneurysm, so tiny that even the blood can't be detected, but yet it's causing widespread vasospasm." Okay. And then there were other theories as well. It wasn't until much later that I figured out that everybody was, thinking differently, but it needed my own research. So I spent the next several years going down to the Harvard Countway Library and pulling up papers from the late 1800s all the way through to the 2000s, so over 100 years worth of literature. And then I figured out that mainly from the 60s to the 2000s, over the past 40 years, the same clinical angiographic syndrome with bad headaches, strokes, angiographic narrowings had been described with varying terminology depending upon the specialty. So the obstetricians were calling this postpartum angiopathy in women who developed it after delivery. Migraine angiitis, the rheumatologists were calling it benign angiopathy because it was kind of like a vasculitis, but didn't behave like it because of its spontaneous improvement. So they thought it was a benign vasculitis or angiopathy. And then at my own hospital, the great C. Miller Fisher proposed in 1988 with Gregory Cole, who I think is out in Texas now. He was the stroke fellow at the time, and Marie Fleming, that maybe this is a vasoconstrictive process. So full credit to Dr. Fisher. And this in the field of neurology and stroke became known as the Cole or Cole-Fleming syndrome. But yet the entity was widely under-recognized. And I proposed very tentatively as a fellow that this could be a vasoconstrictive syndrome. And all these things really reflect the same clinical angiographic phenomenon. So in summary, it's really, different pieces depending upon which angle you look at it. And credit to Dr. Fisher. When I presented my ideas to him, he said, "Stick with it. I think you're on to something." And with those first couple of cases that I presented to him, I stuck with it. And today I think we've made sense of what this issue is. And ironically, Fisher took away the term vasospasm from our lexicon, which had been sort of considered the mechanism for stroke since Hippocratean times. But it was Dr. Fisher who described the pathological entities like atherosclerosis and atrial fibrillation as a cause for stroke. And then he brought it back. If we think about, I don't know if this is the right term, vasospasm, but he described narrowing of arteries, which is reversible, as a vasoconstriction in this paper I referenced earlier. So what have I learned over the past 20 years? Well, I've learned that it's probably a group of conditions characterized by usually almost always reversible, but at least dynamic changing, segmental, constriction and dilatation of cerebral arteries on serial angiography. It predominantly affects women. Almost every patient I've seen has come in with recurrent thunderclap headache, at least one or two, usually four thunderclap headaches. Invariably, the earliest MRI is either normal or just shows a little bit of convexity subarachnoid hemorrhage along the hemispheres. Convexity subarachnoid hemorrhage is different from aneurysmal subarachnoid hemorrhage. Aneurysms, when they rupture, the perianeurysms, they rupture in the circle of Willis, so they cause sylvian bleeds, basal cisternal bleeds. This is a different phenomenon. It's along the surface. And if you keep imaging these patients, about one third will go on to develop infarcts, a brain hemorrhage, a reversible edema, which is identical to what we're all more familiar with, the posterior reversible encephalopathy syndrome. RCVS is self-limited. 95% of patients have a completely benign outcome. They walk out of the hospital. The headaches resolve, and then the angiogram resolves, but they're not concordant in terms of resolution. And as I said, there's no specific treatment, and a few patients who anyway have a prior history of headache and depression do go on to continue with headache and depression. We looked at the time course of development of the complications. So as you can see here, brain hemorrhage occurs first, because probably that's why the patients present so dramatically. Convexity hemorrhage as well occurs earlier, and then press and finally infarcts are the last to start developing. This is, of course, biased by the function of when we got imaging done and for what reason. So with that limitation, I think this is kind of the time course of developing these various lesions. Okay. Um, Over the past maybe 7 or 8 years, epidemiological studies have now been conducted by groups around the world. What we know is from population-based studies, there's a new ICD-10 diagnostic code. I was on this committee, and it's called the I-67.841. The estimate is 3 per million per year. And then the nationwide inpatient sample based upon the same ICD-10 code estimates 0.02 cases per 100,000 inpatients. I must confess, I think both these are great underestimates of the true incidence, because you can see I see a patient every 3 weeks, not 0.02 per 100,000 inpatients. And I think the difference is the recognition and documentation and using of the code. Not every patient has every element, and not everybody knows about this code. So I think there's a lot of under recognition if you use only the codes. Another way to think about it is in the emergency department, thunderclap headache is one of the most common presentations, and primary thunderclap headache overlaps with this syndrome. The main difference being you have angiographic narrowing visible, you call it RCVS. If you don't, you call it a primary thunderclap headache. And other cohort studies from France, Taiwan, Korea, Cleveland Clinic, Canada, Miami, they've all shown the same female preponderance, and usually the middle-aged people who are affected. It is vasoconstrictive. We've done autopsies on the rare patient who hasn't made it, and in them, we've harvested multiple arteries. None of them have ever shown vasoconstriction. What they do show is this curious, if you can appreciate it, it's the internal elastic lamina that appears very pleated. It's almost like maybe an elastic or something that's been squeezed. So it seems like this is a vasoconstrictive process based upon pathology. What causes it? Honestly, I don't know. I don't think anybody knows. What we've done is we've used our biases and published a lot, all of us. So we know that it occurs after pregnancy, but what's the exact cause, we don't know. Others have reported, that you can get thunderclap headache with vasoconstriction after heavy exertion, after coitus, as in the patient I showed you, even after coughing. If you take an airplane ride or winter climate, expose your scalp to cold water, sudden severe grief, all these things which are physiological or other pregnancy type triggers are associated with this condition. But then if you look at drug exposures, this really exposes our physician biases. Possibly, we've associated the ingestion of various drugs to the onset of the first headache. That's because we like thinking about mechanisms of drugs and implicating them if there's a bad outcome. Epidemiologically, there's no proof that these drugs do anything, with the exception of maybe triptans. Very recently, I think there was a FDA publication that looked at the frequency of adverse events with triptans, and their RCVS stood out as something that was occurring higher than anticipated in terms of frequency. When I look at this list, there are two views. One is that we don't know what we're talking about. This is so divergent and heterogeneous that nothing makes sense. But I also then look at the individual underlying mechanisms of most of these drugs and other things. And what strikes me is that serotonergic and sympathomimetic drive seems to be the common factor. For example, licorice. This was a few years ago. Patient denied any exposures, but then she was consuming a big jug of licorice every day. When we looked into the mechanism of licorice, it has some serotonergic stimulation. So we thought that maybe that's what's causing the RCVS. Over the past 2 or 3 years, there have been cases reported with COVID-19 infection, COVID-19 vaccination, perhaps from the ACE2 receptor, which is implicated in COVID-19. Other patients have been reported with sudden onset headache, but also acute memory loss that recovers in 24 hours, basically transient global amnesia, with narrowing of the stereocerebral artery, suggesting that TGA might be caused by vasoconstriction, reversible, or this is just a strange co-occurrence. We don't know yet. Suzanne Muelstergel, who's now a professor at Johns Hopkins, and she was at MGH training, we compared the subgroups, arbitrary subgroups, based upon what we thought was the trigger. Really found no differences, except, of course, for age and gender, which was different in the postpartum population. But otherwise, there was no significant difference. In speaking with experts such as David Dodick from Mayo Clinic and Len Calabrese from Cleveland Clinic, we've come to an internal consensus opinion, which needs to be investigated and validated, that the raphe nuclei in the brainstem and their projections to the perivascular nerves, which are the so-called serotonergic and trigeminal-vascular pathways, where someone's not muted. So these pathways that land up, the nerves, they land up on the abluminal surface of the cerebral arteries, and they may have a role to play in cerebral auto-regulation. So if there's excess serotonin or excess sympathomimetic release in the perivascular nerves, it might precipitate both the headache, the angiographic narrowings that you see, and culminate in the stroke. And depending upon the mechanism of the serotonergic receptor proximal, it causes vasoconstriction, and more distal, the other serotonergic receptors might promote endothelial leakage and dilatation of the capillary bed. So I think this serotonergic underpinning might explain both the proximal narrowing and the more distal vasodilatation and edema that might develop. Okay. In a patient who passed away, we drew bloods and we found different ratios of anti-angiogenic factors, namely sFlt1 and endoglin, suggesting that there may be other endothelial dysfunction type mechanisms at play. Groups in the Far East have proposed, and this is unvalidated, that there could be some genetic underpinning because they found polymorphisms of the serotonin transporter. Now, again, this was a very small study with small samples, and it's not been validated, so not sure what to make of it. I think I mentioned the patient with TGA who had narrowing of the PCAs. Interestingly, Takotsubo cardiomyopathy, which you might be familiar with as the voodoo heart syndrome with sudden grief or sudden anxiety, you might get ballooning of the left ventricle, the apex, which resembles that of the octopus. So this is called Takotsubo cardiomyopathy, and people have proposed that you can get Takotsubo and RCVS in the same patient, and I've seen a couple. I think it's possible that the same, Takotsubo might also be caused by vasoconstriction of coronary arteries, and in rare cases, you might see both in the same patient. What's really important to note is that RCVS is almost 95% of the time, maybe more, restricted to the intracranial arteries. Systemic affliction is quite rare and is reportable. So with that sort of prelude, now let me get into the bedside. Okay, how do you diagnose, how do you distinguish it from really ominous conditions such as aneurysmal bleeds, What about other arteriopathies and vasculitis? What about migraine? Is this bad, sudden, severe headache just a bad attack of migraine? It turns out that 40% of patients with RCVS will report prior migraine, which is more than expected. But the headache of RCVS is different from the headache of migraine. It is explosive. It goes away. It comes back after 2 days, 3 days. It keeps coming back for the next few days. That explosive headache, like someone, like a firecracker went off on the head, it is the worst pain imaginable, unlike migraine. And then after that series of boom, boom, boom headaches, it doesn't come back. So I think that's different from migraine, which spans decades and is a throbbing, headache with nausea, vomiting, photophobia, other things. So you don't see that in RCVS. So I don't think this is the same type of headache. As you know, migraine is a primary headache disorder. Thunderclap headache, cluster headache, tension headache, they're different types of headache disorders. So I think that's what we're dealing with, two different types of headache disorders, with thunderclap headache being one, and if it's complicated by angiographic narrowing, we give it the term RCVS. Okay? So how do you recognize it? Today, I'm confident when I listen to a story that I'm dealing with RCVS. If I hear a story, doc, I was bending over and I had the worst pain possible. It brought me to my knees, and I just went to bed. And after a half hour, everything was better. I had this lingering headache, and the next day, while I was moving my bowels, the same pain came back. It was as bad as the first time. And then yesterday, when I was mowing the lawn, I had the same headache, but not as bad as the first time. So now a patient has three headaches with peak intensity less than 1 minute. There is no other condition, not sentinel bleeds of aneurysmal rupture, not venous thrombosis, nothing else that causes recurrent worst ever headaches in a span of a few days. That is our CVS. You can put the phone down and make the diagnosis very confidently. Studies have shown that there's an average of 4 thunderclap headaches. I've seen a patient with 28. In the literature, you'll find that RCVS has been reported in the absence of thunderclap headache. Personally, I think it is possible, and I certainly have seen a couple of patients, but it's nowhere close to 30%. I think these are, again, biased reports with patients who come in with encephalopathy, confusion. You ask such a patient, they're not going to recount properly. Or you actually take a stop clock and say, okay, 60 seconds, and that's the cutoff for thunderclap headache. It doesn't work that way. People describe onset, sudden onset in various ways. So if you're a little liberal with the definition, I think you'd agree that almost every patient comes in with recurrent thunderclap headache. Initially, the blood pressure can be labile. These are the deficits, as in my prototype patient that you might see. Hyperreflexia is common, again suggesting some serotonin syndrome or serotonergic overdrive. And if you admit such patients, which you should, and repeat imaging, you'll find that ischemic hemorrhagic strokes or edema develop in about 9% to 63%. Now, this is again a wide range because it depends on how often you image the patient. A lot of these are asymptomatic findings. If the patient becomes symptomatic, you get the usual stroke-like, hemiparesis, ataxia. But most common is the visual deficit. Patients don't know how to describe Berlin syndrome. They say, Doc, I can see things, but it's just blurry. Trust me, that's probably an element of cortical blindness. About 1 in 5, 1 in 10 patients can develop a seizure, but epilepsy, I haven't seen a patient with epilepsy long term after RCVS, so they do not need anti-seizure meds. I work with Jonathan Edlow, who's a professor of emergency medicine across the street, and he and before that David Dodick and Todd Schwett, who's out in Arizona, they've summarized the causes of thunderclap headache. And as you can see from this list, things like brain hemorrhage, venous thrombosis, subarachnoid hemorrhage, dissection, clots going up to the PCA, these are all things that can cause sudden bad headache, and they can have a very bad outcome. So how do you rule out these ominous causes. And I think this is a nice flow diagram that Dr. Edlow has made. First step is to do a stat head CT. If it shows you an organic pathology, as listed here in the yellow box, you're done. That's what you have to deal with. If the head CT is normal, then proceed with a lumbar puncture. The head CT was done more than 6 hours after the onset. If it's done within 6 hours, as you already know, head CT is, you don't need the lumbar puncture. It's very good for the diagnosis. If, however, you're dealing with a patient with multiple thunderclap headache, then you can do the CTA and MRA, and if it's non-diagnostic, repeat it, and you will find RCVS. And even if you don't see the abnormality in a patient with a normal head CT and, say, 4 thunderclap headaches, there's really no other differential diagnosis. It just means you missed the period of time when the arteries were narrowed because it's a reversible condition. I've mentioned briefly the terminology. I think primary thunderclap headache is no different from RCVS, except that the latter condition is defined, at least today, by the presence of angiographic narrowing. That's really the only difference. These authors they're from Asan Medical Center. I think they've enrolled patients with and without segmental narrowing and found that there was really no difference between recurrent primary thunderclap headache and RCVS, which was previously known as benign CNS angiopathy. Another group of authors from Korea, I think they've tried to develop a scoring system to predict RCVS as the cause of the initial the thunderclap headache. It's called the RCVS TCH score. And you can see the pattern of thunderclap headache, the sex of the patient, the triggering factor, and whether or not there's hypertension. These are the drivers of the score, and the score that's 7 or more has pretty good sensitivity specificity for RCVS. The issue with this study is that they excluded patients with aneurysmal bleeds. And I think that's what we as clinicians are most worried about. So if this cohort didn't include them, then I'm not sure that that would be a valid score for my purpose, at least. And secondly, inexplicably, they included primary thunderclap headache in the group of patients classified as non-RCVS, but I've just shown you that it's the same entity. So now you've gone to the bedside, you've considered all the mimics, you've done the head CT, then you do the CTA and you find a lot of angiographic narrowing. In this situation, you have to think about arteriopathies. And these are the more common arteriopathies, intracranial arteriopathies. So I did a study where I took an undifferentiated cohort of patients with any one of these conditions. Just an abnormal CTA was my defining point. And we looked at the outcome of RCVS, and we found that there were variables that predicted RCVS in a certain combination. So my fellow at the time, who's now a professor of neurology in Sao Paulo, Eva, a wonderful person, she created this acronym: recurrent thunderclap headache, or sometimes single, intracranial carotid artery involvement, for which you lose points because you don't get top of the carotid involvement, you get circle of Willis arteries and their branches, which are affected. So this is more moya or ICAD. So therefore you lose points. V is for vasoconstrictive trigger, the list of which I showed you. And the 2 S's are for sex and convexity subarachnoid hemorrhage. And based upon the weights in our model, we created a score. And the score is pretty good, the RCVS2 score. It goes from less than 2 to up to 10, and scores which are 5 or higher have amazing specificity and sensitivity, and also positive and negative predictive value to rule in RCVS. Scores of 2 or lower rule out RCVS, and they favor a non-RCVS arteriopathy with very, very high specificity. I think these numbers are unmatched. I don't think any kind of biomarker study can exceed this kind of specificity sensitivity. And if you look at the variables, all these variables are at the bedside on your first encounter with the patient who has had a CTA and the question of arteriopathy has come up. So I really believe that this score is good for the non-neurologist who doesn't know RCVS and just blindly uses the score. It's worked well. I've tested it for the past 8, 9 years since publication. And because I'm so confident, I made it available on mdcalc.com, which is a website I hope you're familiar with. And here you can simply compute the score. It gives you the result and the next steps. This score, I believe, has practical implications in the sense you can make a prompt diagnosis without waiting for the angiographic reversal and clinical improvement to say, oh, this is RCVS. You can make one up front in the ED. Regrettably, some groups around the world, including the United States, have said that we should take patients with a bad thunderclap headache and angiographic narrowing who seemingly have RCVS. We should take such patients to the cath lab, insert a catheter in their groin, put the catheter up to the brain artery, and then squirt in various vasodilators. And if the artery opens up, you can confirm the diagnosis of RCVS. I'm not in favor of this invasive procedure. It causes anxiety. These are young, otherwise healthy patients. You give them a 1-2% risk of a stroke or some other complication of groin puncture. Moreover, I don't need this dilator response when I listen to the patient's story. So, my plea to all of you is listen to the story. If necessary, look at the score. Call me. You can call me day or night, and I can help you make the diagnosis. You don't need angiograms for this. Other groups have resorted to contrast vessel wall MRI. In my opinion, this is still an emerging tool. Just this morning, I'm on service. We had a patient with faint contrast enhancement, and we're thinking vasculitis, but we don't really know. There is no gold standard, and this tool is lacking a gold standard for defining its specificity. If you do the study and you find no enhancement, maybe you'll be more convinced. But again, it's all in the patient's history. You can make the diagnosis on telephone. Other studies, this is courtesy Cleveland Clinic, Dr. Abbas. They also have capabilities of 7 Tesla vessel wall MRI. We don't have that at Mass General. Maybe we do, but we don't use it. Again, you don't need these fancy tests. Once you diagnose the patient, rest easy. All you got to do is look for triggers, look for mimics. So, very high calcium levels can cause it. Ask for COVID-19 vaccination or recent infection, test for them. You may want to look for antiphospholipid antibodies. I'm seeing a few patients where the IgG or IgM was elevated. I'm not sure what to make of it. Rare patients have been reported of pheochromocytoma presenting as RCVS, maybe 3 case reports. So don't forget to ask for a story consistent with pheo. And because of this issue of Takotsubo and cardiac complications, you might want to do a cardiac ultrasound or a chest CT. Now, I have stopped doing CSF studies in these patients to sort of rule out infection or inflammatory arteriopathies. Why? Because I've seen RCVS being triggered by drops in CSF pressure. And lumbar puncture, dural puncture can trigger bad headaches. So I think it's risky. And I just watch the patient. If they get better, I know it's RCVS to begin with, and then the improvement confirms it. I don't do DSAs if the patient has typical or classic features and a high RCVS2 scores. I reserve this test for patients in whom I'm really uncertain, and that's maybe 1 in 100 where I'm really uncertain. Treatment is easy. Treat the pain. Be liberal with opioids if you need to. This is the worst pain imaginable. Pregnant women say that they'll deliver without anesthesia but cannot tolerate another headache. It's that bad. I think fluids is good. Pain management, the opioids. I give laxatives. I recommend bed rest because exertion can trigger thunderclap headaches. If you find a trigger, you can hold it for a few days or weeks. I don't tend to raise or lower blood pressure. I think it's risky in the setting of constricted arteries to do either. Calcium channel blockers are being given around the world without any proof that they actually work. Nimodipine in particular is being given because of extrapolation from the aneurysmal vasospasm literature. And I'll show you why it's critical. This is a pitfall. Avoid glucocorticoids. You don't want to give a patient with RCVS a course of steroids thinking that this could be vasculitis. Try and avoid that. It really can make things worse. And as stated before, save these invasive procedures for fulminant progressive cases, clinically progressive cases. Okay? And I put a question mark about whether you can re-expose patients to the antidepressant or the triptan. The issue is that there's no epidemiological or hard evidence that the drugs were implicated in the first place. And in my limited experience of about 25 patients or so, re-exposure has not caused any recurrence of RCVS. So I think this is safe, but it needs a more formal analysis. This was my study, which caused a lot of eyebrows to be raised. Keith and I did the study. We classified our patients into those who received steroids and those who did not receive steroids, expecting that the steroid exposed groups would do better, but they actually did worse. This is the cumulative event curve where you can see more events, clinical events, in patients who got steroids. The circles here show you the outcome. This is death, the black. The gray is poor outcome, so MRS of 4 or 5. There are much more black and grays on the glucocorticoid exposed patients. Then we asked ourselves, hey, is it possible that patients were given steroids because they were worsening? So this is an artifact. Actually, it wasn't. We looked carefully at the charts and the medication exposures. They were invariably given steroids because of the thought that we may be missing vasculitis, and then the worsening occurred later, as you can see. This is glucocorticoid exposure. This is the time. So maybe 1.5, 2 days after the fact, they got worse. The mechanism is unclear. I recently spoke to Dr. Gilbert Daniels, a very eminent endocrinologist, and he said, Aneesh, if you have a burn or something on the skin which is red, you put a steroid cream, the redness disappears. I said, yeah, why does it disappear? It takes away inflammation because it's a very potent vasoconstrictor. So probably steroids are also vasoconstrictors, and that's what does. Okay? What about intra-arterial vasodilators? These inverted grays are the vasodilator treatments. And as you can see, the patients didn't do well despite the intra-arterial approach, but it was tried in patients who were already worse. This was after the worsening. Now, this is a issue. I think the literature is replete with case series saying that it's a great thing and it can stop the progression of RCVS. That's not been my experience. And I want to show you this patient who had a bad outcome. This is the patient who came in after delivering twins, 36-year-old woman with widespread, very scary looking vasoconstriction, but the patient was doing well, had a great response to intra-arterial treatment, but then had reperfusion injury and regrettably went to the morgue. So this is the risk of reperfusion with intra-arterial. So in summary, we can diagnose it very easily today. Ask for exposures, look carefully at the CTA and MRI features. Invasive procedures are not necessary, avoid steroids. And then in my experience, because these patients get better, I don't need to document reversal. So I've even stopped doing a CT or a follow-up MRA. The outcomes are excellent. It's very important to see them in the outpatient clinic and even before their discharge. Counsel them. Recurrence is exceptional. The headaches will get better. Once in a while, patients may have one isolated solitary headache, but not this boom, boom, boom recurrent headache with the syndrome coming back. Avoid vasoconstrictors. In future pregnancies, monitor for eclampsia and advise them that a little bit of depression and headache going forward is not uncommon and their children will not be affected. I'm going to spend the last few minutes talking about vasculitis. Vasculitis was described in the 1950s. And in 1988, my dear friend Len Calabrese, along with Malik, published a paper saying that you can develop criteria for diagnosis based upon progressive clinical or psychiatric deficits with a classic angiogram. I'm not sure what that means. I don't think he knows that either. in the sense that the angiograms are typically normal, and if they're abnormal, there's no real pattern to it. And there's no information here about the inflammatory CSF. The point I'm making is this was the original criterion, but it's evolved today. We also know from various cohort studies, the most famous one from Mayo Clinic by Salvarani, that the many pathological subsets, granulomatous is the most common, necrotizing if there's additional vasoconstrictive exposure, and then if there's amyloid deposition triggering granulomas in the vessel wall, we call it ABRA. And very rarely, Calabrese and I reported this solitary mass lesion presentation where you think it's a GBM, biopsy the brain mass, it turns out to be vasculitis. There are many conditions that can mimic vasculitis. This is from that Lancet Neurology paper. RCVS historically has been a mimic, but I don't think today it should be confused. These are the other conditions, brain neoplasms, especially intravascular lymphoma, rheumatological inflammatory conditions, infections, myxomas, other things can mimic vasculitis. And the treatment, again, there's no well-defined treatment protocol. Most of us give oral steroids or pulse methylprednisolone, and then followed up with intravenous cyclophosphamide monthly infusions to try and reduce the number of exposures to steroids. Newer drugs such as azathioprine, methotrexate, mycophenolate, rituxan, these are all being tried in PSCNS. Salvarani studies have found that people who have gadolinium enhancement on the MRI, they tend to respond better to this regimen. The histological subtype does not necessarily predict response, and relapses are much more common, especially in patients with focal deficits, cognitive impairment, encephalopathy, multiple infarcts to begin with. So it's a bad disease. Now, the issue with this overlap dates back to the 50s when PSCNS was first described. The world over, we thought that it's a uniformly progressive condition. Patients are going to end up doing very badly. And then, because of this fear of missing vasculitis and delaying the diagnosis, physicians started taking shortcuts. They started making the diagnosis solely on basis of clinical features and an abnormal angiogram. And thus, they missed the fact that people with headache and bad angiograms could have a benign self-limited condition called RCVS. So in other words, patients who truly had RCVS, and I think it's still going on, are being exposed to the risks of open brain biopsy, CSFs, chronic immune suppressive therapy, which itself can lead to fatal outcome. So this is one of the Salvarani series that I reviewed, and you can see here the angiogram constituted the diagnosis of PSCNS, even if the biopsy was negative in 18 patients out of 101. And in others, the biopsy was not performed, but they still made the diagnosis. So 70 out of these 101 cases from the Mayo Clinic, I don't know if they truly had vasculitis, okay? It's possible that there was some contamination with RCVS over here. There's an ongoing French study group called the French Vasculitis Group. Again, they're reporting a very higher frequency of brain hemorrhages, convexity subarachnoid hemorrhages in a quarter of their patients, and then the abnormal angiography in 57% in proximal arteries. That has not been my experience with primary angiitis of the CNS. What I've done is I've done a retrospective analysis of the MGH data, and we found that RCVS, PSCNS, the age group is lower, more females in RCVS, more vasoconstrictive drug exposures. Thunderclap headache is much more common. So there are major differences clinically between the two. And then even on the lab and clinical parameters, the CSF is invariably normal over here, but 74% have abnormal CSF in patients with primary angiitis. And look at the difference in outcomes. See, 86% walk out of the hospital with RCVS versus 45% here. The 2.5% can die in the hospital from RCVS. This is mainly iatrogenic because of glucocorticoid or invasive procedures with complications. The infarct patterns are quite different. With RCVS, you typically get a normal brain scan or just a T2 hyperintense signal in the sulcal space because of a dilated artery, or watershed infarcts, press, and sometimes hemorrhagic lesions. Whereas in vasculitis, you also get infarcts, but they're not watershed. They're sort of deep in the basal ganglia with white matter change, leptomeningeal enhancement, or the brain mass lesion, as I showed you, or rarely with territorial strokes or bleeds. The angiographic appearance is different. RCVS is more symmetric, more severe, the narrowing. With vasculitis, the narrowings are not as severe and it's more asymmetric. So you can really distinguish one entity from the other very easily looking at the variable of headache. It's very different between the two. Thunderclap versus non-thunderclap, watershed versus small infarcts, the common presentations with hemorrhage, convexity, bleeds, and brain edema, which is almost unheard of at the first presentation of PSCNS. And then finally, the actual angiographic appearance. So many years ago, don't forget that vasculitis, primary angiitis of the central nervous system, is restricted to the brain. We don't know the cause, but there are mimics. I mean, one is varicella arteritis. This is one of the first cases in a 14-year-old child that I saw. We published it. And at that time, we didn't know what it was, but post-contrast T1 showed enhanced vessel wall enhancement. I think this might be the first depiction of vasculitic vessel wall enhancement on a plain MRI, not even a 3 Tesla MRI. And this patient had prior chickenpox. The CSF was positive, responded to acyclovir, and did well. Another subtype, as I told you, is the amyloid vasculitis or ABRA. This is when you get amyloid beta deposition in the vessel wall with inflammation. It looks identical to primary angiitis, except that there's amyloid deposition. And this is different from inflammatory CAA, where you get inflammation outside, but not in the vessel wall. Okay? And the one mimic, people often ask me, why should you do a brain biopsy? Well, you don't want to miss things like intravascular lymphoma or varicella. In lymphoma, you can get a similar MRI appearance with small vessel infarction, but then you might see lymphoma with the treatment of which is quite different. I'll end by saying that very recently I had the privilege of doing a CPC, a blind CPC with the diagnosis unknown of a man who came in with recurrent strokes. He had this spiculated mass, okay? And he had not bad looking arteries, but he had this white matter change, multifocal strokes. As you can see, the forceps major, deep territory. This is sort of the vasculitic pattern. He also had vessel wall enhancement. So clearly we were dealing with a vasculitic phenomenon, but I didn't know what to make of the spiculated mass. And I proposed this could be a paraneoplastic vasculitis. That's what it turned out to be. So the spectrum is expanding. But so keep your eyes and ears open, work up for potential mimics. And with that, I'll stop here and open it up for questions.
I'm not sure if you can hear me.
It's a bit scratchy, so if you want, you can type it out, Sean, or have someone else.
Stuart's going to do it.
Hey, yeah, I'm happy to answer any questions or say any questions that are typed into the chat for us.
I do have a question if it's a possibility.
Of course, go ahead, Ali.
Yeah, thank you very much for the great talk. I've been waiting for it since I saw the the announcement. I just have two questions, if you don't mind. One question is regarding RCVS, and the other question is regarding vasculitis per se. The first question regarding RCVS is, in your vast experience with this topic, have you ever seen a painless RCVS? Like family confirm, patient is not encephalopathic and he confirms as well, but it just, for example, a young patient with convexity subarachnoid hemorrhage, unexplained, with a possible RCVS pattern. And my other question is regarding vasculitis. It's mainly vasculitis versus vasculopathy. Do the time or do having a prior scan in terms of CTA or MRA, uh, do you consider it helpful for patient with vasculitis versus vasculopathy? Like, for example, patient with multiple strokes, but he had these, like, for example, 2 or 3 strokes over the course of 5 years, and the CTA findings have been the same for like the last 5 years. Versus, would that tend you more toward a vasculopathy, or would that still concern you for like a kind of like an inflammatory vasculitis pattern in terms of that like degree of how many time have elapsed?
Very good questions, Ali. First of all, thanks for being interested in this talk. The first question is, have I ever seen painless RCVS? The short answer is yes, maybe 1 in 300 cases where I was really stumped about the absence of pain. In the literature, as I showed you, 10% up to 30% seemingly have no thunderclap headache and possibly no pain either. It's very rare. I think we have to question the diagnosis. I think the issue here is I think it's the headache that comes first and the vasoconstriction follows. And I think the two are very closely linked. So to get the features of sausage on a string appearance with convexity bleed with reversal in a few days, if you see that, I think you should publish it. It's rather rare. It can happen. But you must think of other conditions that cause convexity bleeds with maybe some angiographic narrowing. I mean, the patient could have, if above 60 years of age, the most common cause of convexity bleed is cerebral amyloid angiopathy. So if a patient has, for example, a bit of athero causing multifocal narrowing and then amyloid angiopathy, you shouldn't be missing that. And so just be careful of that. The second thing is in a patient who's gone 5 years with multifocal strokes and a fixed arteriopathy. 5 years is a long time, but then the patient has had progression. So yeah, the short answer is it could still be vasculitis. I mean, I might favor athero or something else a little more in such situations of 5 years being untreated. But we don't know enough about vasculitis, and I think we have to be humble and acknowledge that and be open to suggestion. This is a very treacherous diagnosis. The average time to diagnose is about 6 months. And people make the diagnosis without formal confirmation on pathology. So we have to be very careful of that, of what's there in the literature about this condition.
That's great. There's a few questions in the chat I'll read out to you. Sean asks, what do you think of using high resolution vessel wall imaging to differentiate primary angiitis of the CNS and RCVS?
Yeah, thanks, Sean. So as you know, vessel wall imaging doesn't have the specificity, I think. I've seen patients with RCVS who have enhancement of the vessels, and I've seen patients with biopsy-proven vasculitis who don't have enhancement. So I personally rely upon the patient's story. If it's thunderclap headache, I don't think I've ever seen a bona fide patient with PSCNS coming in with thunderclap headache. The second thing is on MRI, the brain parenchyma is initially normal in RCVS. 70% of patients reported by the French group, reported by our group, they may have surface bleed, but they don't have anything in the brain parenchyma. If you keep repeating scans, you might find some press or developing infarct or something in the brain parenchyma. That's RCVS, the conversion of a normal scan to an abnormal scan. But in the Mayo Clinic series and many other series, 99.5% of patients with vasculitis came in with infarcts or white matter change or some other abnormality on the scan. So I think I listen to the story and then I look at the images. That's enough for me to distinguish. I don't need a $3,000 test to further inform me.
A couple more questions, if I could. So we had talked about postpartum RCVS. one question asked specifically, how often do you see RCVS in postpartum patients who get spinal anesthesia? Is there a correlation with spinal anesthesia, to your knowledge?
I've read about a few cases and I've seen a couple, Stu, but I don't know the numbers. I mean, I haven't analyzed it with the viewpoint of is this a risk factor? What I do know is even in the Carl Fleming paper, a few patients from Tufts, I've seen where the RCVS was precipitated by dural puncture. So I think there could be a correlation, and Dr. Fisher himself told me that it could be something to do with drops in CSF pressure that cause a lot of the angiographic narrowing. So I don't know, but I think there could be a correlation. Okay, and then 1/3 of RCVS show press. Oh yeah, okay. So Alberto Maud asked us if 1/3 of RCVS patients have press-like changes, how many press patients have RCVS? And the short answer is this has been studied. There's a paper in the American Journal of Neuroradiology by Walter Bartinsky, and he took a series of patients with press who had MRA and found that 49% of the MRAs showed features of RCVS. So I think there you go. There's another overlap. So about half of them will have it. There's one more from Zishan Haider. Potential in targeting specific serotonin receptor subtypes. Yeah. Zishan, that's another very thought-provoking question. I think there's value in that because the pain is so severe, and in a minority of patients, they can be pain for more than a few days. There have been case reports of various strategies, including ranitidine receptor blockers, dantrolene and other things. These are all spattering, one or two case reports here and there, so we don't have a uniform strategy. I was giving grand rounds at Tufts a few days ago, and David Hiller said, why don't you do a clinical trial? The issue is it's not such a common condition, even though I think it's common in MGH. I mean, nationally, it's a benign self-limited condition. So how do you do a trial when people are going to get better by themselves? It's not easy. So that's why I haven't done it. But I think if you have a difficult case, I've personally given cyproheptadine, which is a serotonin antagonist, and I haven't seen much of a difference there. But only 2 or 3 cases, so I cannot draw a conclusion. But I would encourage you, because these are severe headaches, if there's a benign treatment, you might as well try it, I think. Avoid steroids. You can do anything else you want.
I had a question. Thank you, Dr. Singhal. This was a fascinating talk, excellent talk. Learned a lot. This is Haris Kamal. I was wondering about this diagnostic dilemma that sometimes we encounter in these medium vessel vasculitis patients, who are having strokes and they're in the ICU, deep subcortical strokes, and then you do an angiogram and you find, the medium stuff, which is where you don't see a lot of, it's hard to call it ICAT versus not. And then, the question I had specifically was on CSF testing, is lymphocytic predominance in these medium vessel cases kind of a hard cutoff to be able to trust that, if you're not seeing lymphocytic predominance, then it's probably not going to be an inflammatory vasculopathy.
So I can only speak for my own data. 29% had completely normal CSF in the presence of biopsy-proven vasculitis. So the absence of inflammation does not rule out vasculitis. In fact, 1/4 of patients. I think what you need is a multidisciplinary approach. You need to look at the full picture, the progression, the pattern of infarcts, the degree of abnormality, and the CSF. And then eventually it's a brain biopsy, which is, again, 25% can be false negative. But in my hands and at Mass General, we spend a lot of time sitting with the neurosurgeon. I'm sure you do the same. And you tell them to target a specific site which is showing enhancement or a recent stroke or something to increase the diagnostic yield. I had one patient where the surgeon went in and they didn't biopsy the right site. So I sent the patient back for a second biopsy and it showed the lesion. So you have to be very careful of how you do these things. You can't just send a patient to a surgeon and say, do an open right frontal brain biopsy and expect that it'll show you the result. Try and use stereotactic targeted sites for biopsy. This is,
Sure.
I
Yeah.
tell you,
Thank you.
this is getting a diagnosis of a proper cerebral arteriopathy is very difficult. There is no gold standard, even for ICAD. We're biased because we say, oh, patient has hypertension, diabetes, there's a bit of calcification, must be ICAD. You don't really know, right?
Yeah, very true. Thanks.
Oh, not sure if you already mentioned the role of SSRIs. Yeah, I did. Yes, SSRIs, I can only emphasize that they're the safest drugs around. So don't think that every patient who has a stroke who's on an SSRI, that the SSRI somehow caused the stroke. Okay, with that background, I have been implicit in this. I've said that three patients I saw in the first of the first 5 cases, 3 were taking a combination of SSRI, diet pill, cough and cold remedy. And I propose that maybe it's a combination of the meds that somehow triggered vasoconstriction. We don't know if that was true. There's been no epidemiological evidence to state that that's true. But logic is logic, and if you think recent exposure can somehow trigger RCVS, it makes sense to withhold this SSRI for a few days. And once the spell is behind them, in other words, no more headache, they're back to normal, I've re-exposed them without any consequence. Yeah.
Thank you, Dr. Singhal. I have one more question. Again, we don't have a very clear hypothesis there, right? But there are some patients have association with the aneurysm, developing aneurysms and subarachnoid hemorrhage. What is the prognostic implications in the long-term management in those patients?
Mean of unruptured aneurysms in these patients?
Yeah. Who may develop unruptured aneurysms or subarachnoids?
This is a very complicated question. There's a higher frequency of unruptured aneurysms in patients with RCVS. I've shown this. There was a very famous case report in Lancet in 1988 by John Day and Neil Raskin from UCSF of a patient who had multifocal vasoconstrictions, recurrent bad headaches, and an unruptured aneurysm that gave rise to the notion that unruptured brain aneurysms can cause headache and vasospasm, so to say. Today, we know that that patient and others probably had RCVS with the coincidental finding of an unruptured aneurysm. I think it's a common finding which might denote some ultrastructural abnormality in the vessel wall or connective tissue that predisposes to both the aneurysm formation and the development of RCVS, possibly. I don't know. But the unruptured aneurysm should be followed as you do any other patient, right? You should do serial angiography. If it's at the right size and the location, then you might want to clip or coil it in the future. Yeah.
Thank you.
Ali, one more question?
Yes, thank you. Dr. Singhal, just a quick question, regarding challenging cases, just to echo Dr. Kamal, question regarding, patient in ICU with doing angiography, if there's no family or patient is, homeless, there's unclear whether it is RCVS or vasculitis. Do you think like the IA verapamil during diagnostic angiogram is a reliable test enough to be able to differentiate it?
Would you mind repeating the question? Sorry.
Oh yeah, absolutely. It's just in regard of differentiation between vasculitis and RCVS, especially if there is no clear history. For example, patient is homeless, no family, patient is encephalopathic in the ICU. Do you believe that IA verapamil, in your experience during diagnostic angiogram, is a good test enough to be able to detect or differentiate between like reactive vasculopathy, RCVS versus inflammatory vasculopathy?
Again, I think focus more on if you don't have a history at all, and if you have a patient who's unable to provide any history, is encephalopathic. The question is, you have a CTA, right? You're suspecting an arteriopathy because the CTA is abnormal. So you don't need an angiogram to reconfirm that the arteries are abnormal, number one. So before you go to the step of injecting intraarterial substances, look at the MRI if possible, look at the pattern, and look at the serum toxicology, and wait for a few days. Nothing's going to happen to a vasculitis patient over the course of the next 48 to 72 hours. This notion that we have to blast them with steroids and start treatment the very next day is unfounded, because the average time to diagnosis is 6 months and the complications occur much later on after that. So my suggestion is to wait and let the condition evolve. If you're really desperate, sure, then take them up, and if the patient is worsening in front of your eyes, there's absolutely no harm in trying anything you want. Vessel wall MRI, try intraarterial to try and make the diagnosis. Now, the caveat is some patients with intraarterial injections can show a little bit of dilatation even if they have vasculitis. Okay, so be careful of that confounder.